yields back, and now it's a pleasure to recognize the gentleman from Virginia, Mr. Griffiths, for his 5 minutes of questioning.
Thank you very much, Madam Chair. And clearly, somebody said it earlier, we have to identify that we have a problem, and clearly that has been identified. And we heard the testimony last year of Mr. Johnson. We've heard your testimony today, Ms. Irvin, and those losses where the mothers were they just weren't paid attention to. And that clearly is a concern. But I was struck, Dr. Howell, by one paragraph in your testimony. And I'm going to repeat that paragraph because I think it's helpful, and then I'm going to ask you a question. Quoting your testimony. Research by our team and others has shown that for a variety of reasons, Black women tend to deliver in a specific set of hospitals, and those hospitals have worse outcomes for both Black and white moms regardless of patient risk factors. This is true in the United States overall, where 3/4 of all Black women deliver in a specific set of hospitals, while less than 1/5 of outcomes in those hospitals. While less than 1/5 of white women deliver in those same hospitals. Both Black and white women have worse outcomes in those hospitals. In New York City, a woman's risk of having a life-threatening complication in one hospital can be 6 or 7 times higher than in another hospital. Black and Latina mothers are more likely to deliver in hospitals with worse outcomes. In fact, differences in delivery hospital explain nearly 1/2 of the Black-white disparity and 1/3 of the Latina-white disparity in severe maternal morbidity. So here's my question. They're choosing a specific set of hospitals. How do we fix those hospitals? And should we have some way of getting the information out, if we can't fix those hospitals, that these hospitals are far more dangerous? Doesn't solve all the problems, but your testimony indicates that 1/2 of the disparity is because of specific hospitals. Nothing else that we're doing here at the federal level or the state level, but the specific hospitals they're chosen. How do we fix them?
So I think what's interesting about the work we've done in New York City is that it's not the traditional hospital characteristics. So it's not percent Medicaid. You know, the median percent Medicaid in New York City hospitals is like 80%. So we're talking about a highly, 60% of our deliveries are covered by Medicaid. So it's not volume. It's much more. We don't really understand why there's such variation other than having to go in and talk to hospitals, and that's what our research team is doing. So we're going into hospitals who have low rates and hospitals that have high rates to try to understand what the differences are. And what we're finding is that it is things like staffing. It's things like culture of the culture of the institution and the way that they treat adverse events. It's things like communication and the emphasis. It's quality and safety on labor and deliveries and the use of evidence-based practices, but it's also whether there's any focus on equity and diversity and how they think about it. So more work needs to be done to understand these variations, especially in large urban centers where you have high volume. But that is one key important piece, because in certain hospitals, regardless of what you look like, your risk is higher to have one of these severe complications. And that is an important part of the story we're talking about today.
And so while we look at these bills, and I think this was the same point that Mr. Guthrie was making just a minute or two ago, and he and I hadn't talked about what we were going to discuss, but he started hitting some of that same testimony, is that while we're working on this legislation, that's an area we need to focus on. And right now, while there's some studies in these bills, I don't think the bills are really focused on that area. And maybe we need to give some more money to the NIH to focus in on that so that we can figure out what the problem is. And maybe they need to be doing what Dr. Nelson's doing in Texas, but maybe that doesn't work in New York City, because what works in Texas might not work in New York City. But we still need to figure out if that's half of the problem, then it ought to be addressed in some of our bills as more than just a casual line in a study. Would you not agree, Dr. Howell?
I think that it is one important part of something that needs to be addressed. So yes, I do agree that it's one more element that we need to look at, and a very important one in New York City.
And Dr. Nelson, you'd be more than happy to talk with anybody who wants to figure out what you're doing right. Is that correct?
Yes, sir.
And you'd be willing to work with these hospitals that in the testimony are just listed as, and I'm not asking for names today, a specific set. Dr. Howe, real quick, I just have a few seconds left, but should we identify for the public that those specific set of hospitals where your risk is higher?
So I think that, Dr. Nelson, I think we both agree that measurement is a key. Quality measures that are important and that women can use to help choose hospitals, I think is an important measure. But we have to be very careful about the development of appropriate risk-adjusted quality measures so we do not penalize the hospitals that take care of the sickest and the hardest cases. And I think that's a really important part of doing really well-done quality measure development in maternal health that focuses on both the patient, patient-centered, thinking about experience, as well as on disparities.
Thank you. I'm out of time. If the chair lady would like to give you time, Dr. Nelson, she can, but I'm out. I have to yield back.
Well, the gentleman yields back, but I think that his question to you is really very, very important. All of the collection of the data is essential so that you have something that's foundational. But we already know where women of color deliver and die. So there has to be, I think there needs to be a red light and siren team that gets into these hospitals. And I also think that we should consider the accreditation of that hospital based on the morbidity rates. So I don't know if that's what where the gentleman was going, but it certainly is my sentiment.
Will Dr. Nelson respond to that?
Certainly.
So one of the comments of sharing, in all seriousness, sharing our experiences and what we do as practices is actually part of the outreach, and one of the things that we actually stress as part of the regionalization of care. We actually have an outreach team going to lower level facilities to talk about emergent response to hypertension and labor management. So that actually is one of the existing programs we currently are using right now.
But I mean, I don't know if El Camino Hospital in Mountain View, California knows what you're doing, and I'm not saying that they have a problem. It's marvelous what you're doing, but this needs to be under a national umbrella, and I don't think anyone is arguing with that. It's a pleasure